everyone. I am Dr. Cce Unmicrc. I am working as a cardiac anesthesiologist in Department of Cardiac Anesthesia at Cce Unmicrc Institute of Cardiology and Research Center. I am professor here, and this is the topic I am taking systemic inflammatory response syndrome on part of the continuous cardiac education for the continued relay in the YouTube. Basically, this systemic inflammatory response syndrome is why we are thinking of this systemic inflammatory response syndrome and why we are worried for that. In the recent advance in the cardiac anesthesia, there is so much improvement in the outcome of the patient due to the perioperative care, better technique of cardiac anesthesia, better technique in the perfusion technology, and better monitoring, invasive as well as non-invasive. So there are less number of the complications, and the high-risk patients are safely conducted under anesthesia in the cardiac center. There is a less than 1% morbidity and mortality in the cardiac anesthesia and cardiac surgery in low risk cases, but still less than 65 year of the age patient group, there is large number of the database suggestive of morbidity and mortality rate. Mortality rate is in CABG cases around 4 to 5%, and in the aortic valve cases it's 5 to 9%. So there is still high risk for this patient, and this is only for the mortality. Even morbidity and cardiac complications and are higher than these. And more than 75 years of the age patients, there are a high risk of the morbidity, even more than 9% mortality. And morbidity including the atrial fibrillation, low output syndrome, and the LV dysfunction. That can be required the multiple inotropic supports and non-cardiac complications like the renal complication, gastrointestinal complications, and other lung injuries, neurological incident, stroke, etc. are still more than 50% are the complication rate in the cardiac surgery when it's considered to the high risk patient. So all these are due to the many times is due to the inflammatory response syndrome due to the trauma of the cardiac surgery. So we are worried for inflammatory response in the cardiac surgery. In my topic, these are the outline, definition and diagnostic criteria, risk factors, pathophysiology, prognosis, treatment, and preventive measures. I will discuss one by one. The systemic inflammatory response syndrome is a systemic level of the acute inflammation that may or may not be due to the infection and is generally manifested as a combination of the vital sign abnormalities including fever or hypothermia, tachycardia, and tachypnea. Criteria for the SARS are requiring two of the following four features of the patient present: temperature more than 38.3 or less than 36 degrees centigrade, tachypnea, respiratory rate more than 20 or minute ventilation more than 10 liters in case of the adult. Even criteria change with the pediatric patients, and tachycardia, heart rate more than 90 per minute in the absence of intrinsic heart disease, and the total number of the WBC count more than 10,000 or less than 4,000 per cubic millimeter, or more than 10% of the bent form of the cells in the differential cell count. Criteria for the severe SARS are must meet the criteria of SARS plus one of the following criteria, like there is altered mental status of the patient, systolic blood pressure less than 90 millimeter or fall in the blood pressure more than 40 millimeter Hg of the baseline, impaired gas exchange, PaO2 FiO2 ratio less than 200 to 250, and there is metabolic acidosis, pH less than 7.3 or lactate more than 1.5 times than the normal of the baseline, and oliguria less than 0.5 ml per minute per kg urine output, or renal failure symptoms occurred, hyperbilirubinemia, coagulopathy, platelets less than 80,000 to 1 lakh per cubic millimeter, and INR more than 2, APTT more than 1.5 than the control, or elevated fibrin degradation product, that is more than 200 milligram percentage. There is an interrelationship among the SARS, sepsis and the infection. There are various things are considered. Patient can have the SARS and patient can have the infection. So bacterial infection, viral infection, fungal infection, parasitic infection, etc. Few criteria are considered as a clear-cut sepsis and few are merging, overlapping with the SARS. SARS also having the, due to this, there is pancreatitis, burns, cardiac surgery, trauma, road traffic accidental trauma, etc. having the some symptoms common with the sepsis. Risk factor for the SARS or sepsis are extreme of the age, involving lines, catheters in the patient, immunocompromised state, malnutrition, alcoholism, malignancy, diabetes, cirrhosis, male sex, and probably genetic predisposition also participate in the SARS. Pathophysiology of the SARS. SARS is itself defense mechanism actually. Inflammation is the body's response to non-specific response to the chemical, traumatic or the infectious stimuli which involve humoral and cellular response, and there can be a complement and cytokine cascades. So both the immunity, cellular level immunity or the chemical level, and the complement and the cytokine, they are participating in production of the SARS. Bone summarize 3 stages process for the SARS. Stage 1, due to the insult, cytokines are produced at the site, causes inflammatory response and promote the wound repair. This is essential for the normal host defense, homeostasis, and local inflammation causes rubor, tumor, dolor, Kehler, functionalism. Dolor is pain, Kehler is heat, and functionalism, there is loss of the function. All you know all this in your second year MBBS pathology. Coming to the stage 2, small quantity of the local cytokine release in the circulation improve local response and stimulate the growth factor. This acute phase response well controlled by pro-inflammatory mediators and endogenous antagonists. At this stage, some malaise and low-grade fever patient can have. Coming to the stage 3, if homeostasis is not restored, SARS will develop, and cytokines leads to the destruction rather than the protection. Activation of the numerous humoral cascades and activation of the reticular endothelial system and loss of the circulatory integrity. This leads to end organ dysfunction. Multi-hit theory causes progression of the SARS into the modes. Coming to the mechanism of the action, like tissue injury will cause release of the endotoxin, and contact activation causes factor 12 activation, coagulation factor 12 activation, and all leads to the ischemia and reperfusion. Cells and mediators are released like complement, cytokines, like tumor necrotic factor, interleukin 1, 8, 10. Leukotrienes, prostaglandins, endothelium platelet activating factor, neutrophil, monocyte activation, kallikrein and bradykinin, contact activation of the factor 12 activation. All this leads to the signs and symptoms of the SARS like fever, diaphoresis, rigor, mental status changes, hypotension, tachycardia, nausea, vomiting, etc. And mechanism behind this are oxygen free radicals excreted, microvascular occlusion, there can be a fibrinolysis, and as well as there can be a thrombosis. Both can be occur, and capillary leak including the nitric oxide synthesis and neutrophil elastase. All this leads to ultimately end organ effect in myocardial depression, renal dysfunction, coagulopathy, like disseminated intravascular coagulopathy can also occur, pulmonary injury, intravascular thrombosis, hepatic dysfunction, multiple system organ failure, and at the end it can lead to the death of the patient. So, release of interleukin 1 and tumor necrotic factor alpha leads to the cleavage of the nuclear factor Kb. that is NF-κB inhibitor, which initiate production of the mRNA, which induces the production of other pro-inflammatory cytokines, and research suggests that glucocorticoids may function by inhibiting this NF-κB factor. Tumor necrotic factor alpha and interleukin 1 released in large quantities within 1 hour of the insult. Any insult within 1 hour, these factors are uploaded in the blood and causes severe lung injury, hypotension, and when these are together present in the body, they causes fever and the release of the stress hormones like norepinephrine, vasopressin, activation of the renin-angiotensin and aldosterone system, etc. Interleukin 6 stimulate release of the acute phase reactants such as the CRP reactive protein and prolactin. So initial phase of this can cause increase in the CRP and prolactin. These are marker of the CRP is particularly marker of the inflammation. Either it can be due to the inflammation or it can be due to the infection. Prolactin of course can not be present normally, but if it's prolactin is present, we consider there can be some infection component pre-operatively, but post-operatively prolactin also may be high, slightly high in the inflammation condition. Pro-inflammatory interleukins function directly on the tissue or work via the secondary coagulation cascade and the complement cascade and release of the nitric oxide, platelet activating factor, prostaglandin and leukotrienes. High morbidity group BOX1 HMGB1 protein present in the cytoplasm in the nuclei of cell secreted by the innate immune cells and released passively by damage the cells. HMGB1 potent pro-inflammatory cytokine involved in the delayed endotoxin lethality and can cause the sepsis also. So this is the schematic diagram of the contact activation of the complement cascade during the cardiopulmonary bypass. This contact activation of the blood to the CPB circuit causes directly by the classical pathway or the alternative pathway and stimulate the C3 complement 3, and it also causes the affected 12 to activate and make the affected 12A, and that can cause the kallikrein to kallikrein, and there is also plasminogen to the plasmin formation. All this ultimately leads to the aggregation of the neutrophils and expression of the adhesion molecules and leads to the endothelial adhesion and tissue sequestration. This C3 also causes activation of C5A and causes the histamine release, so it causes the anaphylactic like reaction also, and C3 causes the common pathway by C5 and the tumor necrotic factor alpha, and this causes the lysis of the red blood cells. So there are several mechanisms. Mobilization of neutrophils from the bone marrow also occur. All this will cause the signs and symptoms of the systemic inflammation. SARS versus the CARS. Cumulative effect of these inflammatory cascade is unbalanced state with the inflammation and the coagulation dominating. To counteract these, body reverse this by the counter-inflammatory response syndrome. Interleukin 4 and interleukin 10 decreases the production of the tumor necrotic factor alpha, interleukin 1, 6 and 8. Balance of the SARS and CARS helps in determining the patient's outcome after the surgery. If inflammatory markers are more, then there are chances of damage and the morbidity as well as mortality are high, while if these protective mediators are high, then patient will survive whatever the inflammatory or sepsis or whatever the things, patient outcome will be better. Morbidity and mortality will improve if the protective mechanism of the body is powerful. Because of the CARS, many of the new medications meant to inhibit pro-inflammatory mediators may lead to the deleterious immunosuppression. splanchnic perfusion play a key role in this inflammatory system and the sepsis as well. Gut is one of the most susceptible organ to hypoperfusion during the trauma or any kind of the disease. Gut vasoconstriction during hypovolemia or during the CPB is very common, and endogenously released vasoconstriction in a protection to the hypoperfusion of the splanchnic circulation, like angiotensin 2, thromboxane A2, vasopressin, etc., or some drugs used by the anesthetists on the bypass pump during the conduct of the cardiac anesthesia, where the commonly used drug is phenylephrine, which causes the decrease in the splanchnic perfusion and increase in the intestinal permeability to the endotoxins. So there is a increased permeability can cause release of these endotoxin from the gut to the bloodstream, and even in the urine also find the endotoxin level when it is studied. Gastric tonometry measures indirect gastric mucosal PCO2 and difference between the gastric mucosal PCO2 and the arterial PCO2. If it is more than 8 to 10 mmHg, reflect splanchnic hypoperfusion. Hypoperfusion causes regional hypercapnia and CO2 diffuse into the tonometer balloon. Postoperative complications attributable to the inflammation are type of the complication are due to the exaggerated systemic inflammatory response to surgical trauma and the splanchnic hypoperfusion, which causes endotoxin release and adverse effect on the pulmonary and renal, cardiac and vascular system, and it causes also coagulation system disturbances and can cause both anti-hemostatic effect, which can cause the bleeding, and it can also cause the prothrombotic effect, which attribute to the post-operative stroke, deep vein thrombosis, and at the serious complication like pulmonary embolism and other neurological injury chances are high with the due to embolization. Infection is another common complication which commonly affect the wound healing and the respiratory system. CPB causes reduction in the immunoglobulin level through denaturation of the protein, and antibody production by beta lymphocyte is depressed after cardiac surgery, and cell-mediated immunity also reduced due to the decreased level of the T lymphocyte. Thus, reduced antibodies and the beta B and the T lymphocyte function in post-CPB period increases the risk of infection in post-operative period. Coming to the therapeutic strategies for the anti-inflammatory, there are pharmacological strategies as well as the mechanical strategies. Pharmacological strategies include the corticosteroid, serine protease inhibitor, phosphodiesterase inhibitor, antioxidant and no-donors and complement inhibitors. While mechanical strategies are hemofiltration, leukocyte filter, temperature regulation, CPB flow, heparin coated circuit, etc. Coming to the corticosteroids, it improves the post-CPB outcome by reducing the complement activation, C3A, endotoxin release, and tumor necrotic factor alpha and interleukin 168 level. So all these are reduced by corticosteroid, it is suggested. Other is this increasing anti-inflammatory cytokine interleukin 10 levels. Some studies suggest that steroid causes prolonged extubation requiring more vasoconstrictor and more hyperglycemia. So beneficial effect of the steroids are contradicted by these infection chances and prolonged ventilation and the ICU stay. Nowadays studies are there are so many studies which suggestive of there is no role of the corticosteroid in the cardiac surgery while using the CPB, but there are still in the pediatric patient while using the hypothermic circulatory arrest, people are using the corticosteroids in the form of the methylprednisolone. Other setup of the cardiac surgery, mostly people have now stopped using worldwide the steroids. So only indication if deep hypothermic circulatory arrest, and in the pediatric major cases, complex cases, still there is some beneficial role of the corticosteroid. Role of the cardiopulmonary bypass technique. Although heparin coated circuits may have therapeutic advantages, there are fewer clinically significant adverse complications. Steinberg et al. Found no difference in the cytokine level or markers of the complement activation between the patients randomized to a heparin-coated circuit or to a traditional circuit. So there may not be any benefit of this heparin-coated circuit also. While Buruvais et al. Observed lower level of the myeloperoxide and lactoferrin marker of the inflammation with heparin-coated circuit, a meta-analysis involving more than 3,400 patients from 41 randomized trial demonstrated reduction in the blood transfusion and duration of the mechanical ventilation, ICU in the hospital stay, which provides some support for these interventions. So there can be some benefit in the bleeding and total ICU duration on the hospital stay with heparin-coated circuit, but large number of studies and the proper meta-analysis required for these. Centrifugal vortex blood pumping, reduced complement and the neutrophil activation, as well as reduced leukocyte during the cardiac surgery as compared with the standard roller blood pump. So there can be a beneficial effect with the centrifugal pump. Pulsatile versus non-pulsatile flow, there is a splanchnic hypoperfusion may be better preserved. Splanchnic perfusion may be better preserved with the pulsatile flow because of the less endogenously mediated vasoconstrictor, but still studies are required for these. Quigley et al. However, reported a lack of endotoxemia and pathologic cytokinemia with the non-pulsatile CPB. They claimed that use of the adequate blood flow and the perfusion pressure during the CPB conduct will benefit more. So if we can maintain the total cardiac output and LV ejection, and we can maintain the perfusion pressure and the proper volume, then there are less chances rather than all these pulsatile, non-pulsatile and other things. The role of membrane oxygenator to decrease the SARS, there is a less complement activation, better pulmonary function and better host defense as compared to the bubble oxygenator. So there is a beneficial effect of the membrane oxygenator in prevention of the SARS. Role of temperature. Hypothermia probably causes, during the CPB causes worsen the systemic inflammation, but studies found hypothermia reduces markers of the complement activation, tumor necrotic factor, interleukin 6, neutrophil activation, etc. In one of the largest randomized trial to date, 300 elective CABG patients were randomized to either normothermia with 35.5 to 36.5 degrees centigrade or hypothermia 28 to 30 degrees centigrade with the CPB. There was no difference observed in either of the group, so there may not be much effect of the hypothermia, but there is a thing, hyperthermia, perioperative hyperthermia definitely having the deleterious effect on the brain, association between the greater level of the pro-inflammatory cytokine interleukin 6 and the post-operative hyperthermia. So hyperthermia is detrimental for the cardiac overall outcome of the cardiac surgery. Current data suggests that use of the CPB may not deleterious than without the use of the CPB. So if there are beating CABG or on-pump CABG, there are no any beneficial effect observed. Hemodynamic instability and use of the potent vasoactive agent associated with the off-pump technique may be an equivalent insult to the use of the CPB. So while conducting the CABG off-pump, many a time there are so many up-down of the blood pressure and the mean arterial pressure and the cardiac output that can cause the more harmful effect than the beneficial effect of the off-pump. Complement inhibition, the larger randomized double-blind clinical trial conducted to date 3,000 adults undergoing CABG surgery in 2005 hospitals in the North America and the Western Europe were enrolled for the study, and patients were randomized to placebo or to a 24-hour of the infusion of the this pexezumab, which is a recombinant humanized single chain antibody fragment that binds to the human complement C5 and that prevents its activation. The primary outcome variable, death or myocardial infarction within 30 days, did not achieve statistical significance, and the subset of the patients undergoing CABG plus valve did demonstrate a statistically significant difference in the outcome. So it can be beneficial, but still further studies are required for this drug to be giving the positive results. Ultrafiltration, there is of course role of the ultrafiltration method of removal of the excess fluid and pro-inflammatory mediators during the cardiac surgery. In Jornois et al. Randomized 20 pediatric patients, surgical patients, measured tumor necrotic factor, interleukin 1, 10 and myeloperoxidase and the C3a level. He observed lower in all these factors lower in the ultrafiltration group, and patients in the ultrafiltration group had less postoperative fever, perioperative blood loss, time to extubation and postoperative alveolar arterial oxygen gradient. Basically, in pediatric patients nowadays also there are papers coming. There is no much role of the ultrafiltration if due to the better technique of the fluid, better management of fluid, better technique of the anesthesia management, perfusion technology, all can lead without much ultrafiltration. Simple cases can be conducted safely, and in complex cases, ultrafiltration. Conventional ultrafiltration is beneficial. There is no much role of the modified ultrafiltration post CPB, because of the increase in the prolongation of the time of the CPB will be harmful, and there is some role of the zero balance ultrafiltration also while conducting the complex cases. So inflammatory markers, duration of the CPB of course harmful, more duration. So ultrafiltration used in the complex cases, and conventional and the zero balance ultrafiltration, which remove the fluid as well as the inflammatory mediators, can have still some beneficial effect in the cardiac surgery. Leukocyte depletion, removal of the leukocyte during the CPB with an inline leukocyte filter has been proposed as a method for the reducing the concentration of the activated leukocytes. This in turn may prevent the inflammatory mediated post-operative complications. So there is role of these, and a recent study demonstrated no difference in the post-op complication, ICU or the hospital length of stay. But Davies et al. Observed the removal of the platelets and leukocytes by the plasma pheresis reduces the post-op drain and the allogenic blood product administration, but is again a cost. There is a very high cost for this plasma pheresis, and so anybody should balance between the cost effectiveness and the benefit of this leukocyte filtration. Administration of the leukocyte reduced packed red blood cell, either filtering the collected blood either at the time of the donation, fresh filtered, or prior to its release by the blood bank, that is stored filtration, minimize the patient exposure to the leukocytes and post-op mortality, but no difference in the infection, ICU or the hospital length of the stay. Coming to the serine protease inhibitor, aprotinin, alinastatin and nefamstat, all this can cause enhanced homeostasis, antagonize numerous proteolytic enzymes, plasmin and kallikrein, protection against the CPB-induced lung injury, lower the neutrophil and the interleukin 8 count concentration post-CPB, and may reduce the systemic inflammation, inhibition of the thrombus embolism formation. This will improve the microcircular flow and decrease the rate of the stroke. But due to this aprotinin can cause renal dysfunction. There was largely ban on this drug worldwide, but again some centers have started using the aprotinin with its beneficial effect, but still further studies required to again reuse the aprotinin in regular use. Tumor necrosis factor antagonists, anti-tumor necrotic monoclonal antibodies have been studied in specific ICU patients. However, they have not yet been tested prophylactically in the cardiac surgical patients. If TNF and other cytokines are essential to the healing process of the wound or anything, complement inhibition of their effect may result in worse rather than the improved postoperative outcome. Gut therapy, drugs to preserve gut flora, selective gut decontaminated, or to promote the intestinal mechanical function. Drugs are used as laxatives. This may prevent or reduce the release of the gut-derived endotoxin during the cardiac surgery. Selective gut decontamination with the polymyxin E, tobramycin, and amphotericin B, which were started 24 hours pre-operatively, will significantly reduce the interleukin 6 and endotoxin level and no effect on the interleukin 1 or the TNF level. This was the study done by Martinez et al., Critical Care Medicine, 1993. But no difference in the endotoxin level among laxative versus control. So nowadays it's not much used. Phosphodiesterase inhibitor, drugs that increases the intracellular cyclic AMP, decreases the TNF mRNA level. However, a state of hyper responsiveness may occur after abrupt discontinuation of this drug. Interleukin 6 production and the endotoxin release are decreased in patients receiving the milrinone during the CPB. So milrinone is a very safe drug, inodilator, and this will also give beneficial effect in the systemic inflammatory response. Pentoxifylline methylxanthine derivative reduce the pulmonary endothelial permeability in the patients undergoing CPB. So there is emerging role of the pentoxifylline in the cardiac surgery. Statins anti-inflammatory effect have received significant attenuation. Meta-analysis showed that statin are decreased level of the causes decreased level of the interleukin 6, 8, CRP and tumor necrotic factor alpha. However, no improvement in the clinical outcome was observed or reported. N-acetylcysteine, this is used to prevent the radiocontrast induced renal nephropathy and as a antidote for the acetaminophen overdose. It may have the anti-inflammatory and antioxidant properties, so this can be giving beneficial effect. But a meta-analysis suggests N-acetylcysteine may have a beneficial effect with regard to the post-operative atrial fibrillation, but did not appear to be beneficial with the other post-operative complications. So its role is contradictory. Role of anesthetic agents and vasoactive agents. A low dose 0.25 mg per kg of the ketamine before the CPB prevented an increase in the interleukin 6 for 7 days after the cardiac surgery, inhibit tumor necrotic factor production and leukocyte adherence, but there is no large data regarding clinical significant outcome. Isoflurane theoretically may be better than the halothane, enflurane or propofol because of its vasodilating properties, which may preserve the splanchnic blood flow in blood volume. Sevoflurane is equally effective agent for vasodilatation and improving the blood flow. Splanchnic hypoperfusion and endotoxin induced inflammation may be prevented in operating room by strategies using the fluid loading and to the maximize stroke volume and vasodilatation by volatile anesthetic agent and vasodilate if at all require inotropic agent. Inodilator drug like milrinone, they will benefit the patient most. Inodilating agents such as milrinone, emrinone, dopexamine, dobutamine may be more protective of the splanchnic perfusion than the inoconstricting agents such as the epinephrine, norepinephrine or dopamine. Dopamine preserves splanchnic blood flow at low dose. If we use less 3 to 5 mg per kg per minute, that can be beneficial, but more than 5 mg, there is role is doubtful. So it can cause vasoconstriction and decrease in the perfusion of the spleen. Now to summarize, a very large body of the circumstantial evidence strongly suggests that systemic inflammation is an important cause of the morbidity after cardiac surgery. Although several strategies appear promising, there are little data from large randomized trials to support the widespread use of the particular intervention at the current time. And to conclude, systemic inflammatory response is multifactorial and it involves many tissues and organs. Many modalities of the therapies indicate the multiple factors involved in the things mechanism, and no magic bullet to reduce the insult. All patients do not manifest such. It's usually self-limiting condition, and implement techniques that are known not to promote the SIR. Thank you. Any question?